Welcome to The Explainer. Today, we're diving deep into the Advanced Trauma Life Support Protocol, or ATLS. We're going to walk through how to assess a trauma patient from the moment they arrive and cover the absolutely critical process of getting them to definitive care.
You know, the reality of a trauma scene, it can be overwhelming, right? But it's your knowledge, your training, and all that practice that builds the confidence you need to manage the chaos, manage your own emotions, and, most importantly, save a life. So let's break down the system that makes all of that possible.
So, here's our game plan. We're going to start by looking at how you turn that initial chaos into a coordinated life-saving response. We'll cover building a team, then we'll execute the primary survey algorithm, and we'll finish up with that all-important handover of care.
You know, the very first challenge in trauma care, it isn't actually medical. It's organizational. It's about taking a group of incredibly skilled people and in an instant forging them into a high-functioning team that has one single accurate, shared idea of what's happening with that patient. And this is exactly where the ATLS program is so powerful. It gives everyone that shared mental model. It's a common language. It makes sure that the paramedics in the field and the surgeons in the trauma bay are, quite literally, on the same page, creating this seamless continuum of care. You see, effective trauma care isn't just one single event. It's a whole process with really distinct phases. From the planning that happens before a patient even rolls through the door to the debrief after they've left your care. Every single step is designed to optimize performance and, of course, patient outcomes. Now, let's get into the core of the assessment itself. Okay, here we are at the heart of the initial assessment. The A, B, C, D, E mnemonic. It's not just something to memorize. It's a systematic, prioritized tool that forces all of us, to find and fix the things that will kill the patient the fastest. So before we even think about airway, we deal with X for exsanguinating hemorrhage. We have to stop any catastrophic external bleeding immediately. That means direct pressure, packing a wound, or making the decisive call to apply a tourniquet. Because think about it, you can't oxygenate blood that's not in the body. All right, once that catastrophic bleeding is controlled, we move to A for airway. Is it open? Is it at risk of closing? We're looking for any obstruction and we're ready to establish a definitive airway if we need to. And we're doing all of this while meticulously protecting the cervical spine from any potential injury. Now, just because the airway is open doesn't mean the patient is breathing effectively. An open pipe doesn't guarantee flow. So for B, we need to rapidly evaluate the lungs, the chest wall, and the diaphragm to make sure that gas exchange is actually happening. And what's really fascinating here is how some of these injuries are double threats. Take a tension pneumothorax, for example. It doesn't just stop the lung from working. It puts so much pressure on the heart and vessels that it obstructs blood flow, causing circulatory collapse. It needs immediate decompression with a needle or a finger to save a life. At C, we're basically hunting for signs of shock and trying to control any internal bleeding. We're looking at skin color, checking the pulse, is it fast, is it thready, and assessing their level of consciousness. All of this helps us build a picture of their circulatory status. Blood pressure is important, for sure, but it is often a very late sign. You know, the body is smart. It has predictable ways of trying to compensate for blood loss. Recognizing these early, often subtle signs, like a fast heart rate or cool, clammy skin, is absolutely key. It lets us jump in and intervene before the patient's system crashes and their blood pressure finally drops. And this right here, this number, brilliantly illustrates why we cannot wait for a low blood pressure reading, especially in kids. A child can lose up to a third of their entire blood volume before their blood pressure even starts to drop. In these cases, a fast heart rate isn't just an early sign, it might be the only sign of impending collapse. Next up, D is for disability. This is just a quick down-and-dirty neurologic evaluation. We're looking at the patient's level of consciousness, their pupillary size and reaction. Basically, we're trying to establish a baseline neurologic status right away. The standardized tool we use for this is the Glasgow Coma Scale, or GCS. As you can see, it gives us a score, anywhere from 3 to 15, by looking at 3 things: their eye, verbal, and motor responses. The real power here is tracking this number over time. A drop in the GCS is a massive red flag that demands an immediate reevaluation of their ABCs and probably a new intervention. And finally, E is for exposure and environment. We have to completely undress the patient. Why? Because you can't treat an injury you don't see. But in the very same breath, we have to prevent hypothermia. It's a silent killer in trauma patients.
That means warm blankets, warmed IV fluids, and a warm room.
So the XABCDEs, they provide this critical structure, this skeleton for our response. But truly great trauma care, well, it goes beyond the algorithm. It requires sharp clinical judgment and an awareness that we are treating a whole person, not just a collection of injuries.
We always have to adapt our approach. I mean, kids are not just small adults, right? Older patients have less physiologic reserve, and they might be on medications like beta blockers that completely mask the signs of shock. And of course, with a pregnant patient, we are always caring for 2 lives.
This is just so important. How we communicate matters deeply. A severe injury is a profoundly traumatic event, physically and emotionally. So by approaching every patient with empathy and respect, we create a safe environment that actually promotes healing instead of accidentally causing more harm.
Okay, after the primary survey and all that initial stabilization, we reach another critical point, the transfer to definitive care. This could be a transfer to the operating room, to the ICU, or even to another hospital entirely. This handover has to be just as structured and systematic as our initial assessment was.
To make sure that vital information doesn't get lost, we use tools like SXABCDE bar. It's a structured way to communicate that ensures everything gets passed on clearly. You cover the situation, your findings from the primary survey, the patient's background, often using the AMPLE mnemonic for allergies, meds, past history, last meal, and events, then your assessment, and finally, your recommendations. This is how we guarantee continuity of care and keep our patients safe.
So in the end, the ATLS framework isn't just a protocol, it's really a philosophy. It empowers every single member of the trauma team, from the first responder all the way to the senior surgeon, to play their role effectively. By mastering this system, you don't just manage chaos, you actually transform it into life-saving, definitive care.